Hi, everyone. I know you've probably heard this already, but I would like to extend a welcome here to Charleston, and I am hoping that during your time here, you are able to enjoy some of our city as well as the pleasant spring weather we're having here. My name is Michelle Nichols. I am an associate professor here at the Medical University of South Carolina, and it's my pleasure to introduce our next Hall of Fame presenter, Dr. Gretchen Birbeck. Dr. Birbeck holds numerous roles, including the Reichenbauer Professor of Neurology and Professor Center for Health and Technology, University of Rochester, and is actively involved with the university teaching hospitals in Zambia. Dr. Birbeck completed her clinical training in neurology and epilepsy at Johns Hopkins, and she holds board certification with the American Board of Neurology and Psychiatry. Additionally, she has expertise in tropical medicine, epidemiology, and health services research. And her research focuses on neurological disorders on resource-limited tropical areas within sub-Saharan Africa, primarily Zambia. The impact of her accomplishments has further been recognized through countless awards. I also want to say that at the break, I got to see a flavor of her personality when she graciously already extended information on ways to help me further my career. So it's just an indication of the type of person she is. Please join me in welcoming Dr. Birbeck.
Morning, everyone. Thank you for that kind introduction. And thank you, Bruce, for including me today in this lovely program. It's quite an honor to be among you all. Much appreciated. So I had a more complicated topic, but to just step back a little bit, I'm going to really hope to convince you today that we have global inequities in neurologic care. And I'm going to use cerebral malaria as a way to drill down into that. And my fundamental point I hope you will take away from this is that brain health is really devalued and overlooked in many LMICs. And neurologic disorders in general are especially vulnerable. People with neurologic disorders and neurologic care and resources are really vulnerable to inequities in LMICs compared to other types of disorders. I'm going to use cerebral malaria as an example to drill down into this. We're going to go from the worrying about diseases of age to talking about some conditions in children. But I do not think that this is unique to pediatric cerebral malaria. I think this is a phenomenology that is true of virtually all the neurologic conditions that I've cared for over the years in the sub-Saharan African region. And there's some irony here in how a condition that's even called cerebral malaria could be part of a system that really devalues brain health inadvertently. But I hope to convince you that that's the case. For those of you who aren't physicians or took your parasitology a long time ago, just a reminder that malaria is a mosquito-borne parasitic disease that infects red blood cells. And the systemic condition will give you kind of a flu-like phenomenon with very high fevers, untreated or severe could cause liver and renal failure. And the deaths from cerebral malaria occur primarily from one of the parasites, Plasmodium falciparum, and that's because it affects the brain. The pathophysiology of malaria is that the infected red blood cell becomes sticky. It sticks to endothelium throughout the body, but neurologists here won't be surprised when I tell you the brain is the least forgiving organ of this phenomenon. So deaths in malaria are brain deaths. You get sequestration with this parasitized red cell with microvascular obstruction, massive blood-brain barrier breakdown, a horrific pro-inflammatory response, in addition to local hypoxia and systemic disease. And what this looks like in a child is that a previously healthy child, because cerebral malaria has a propensity to affect people with intact immune systems, so a previously healthy child will suddenly become quite ill. Within 24 hours, they can be deeply comatose, often preceded by seizures. And in 72 hours on average, they wake up or they die. It's a very fast disease. It's a very fast, very cruel disease. And malaria remains a very common problem and a common cause of brain injury and neurologic disability in much of sub-Saharan Africa. 282 million infections, 610,000 deaths annually. And if you extrapolate what we expect happens in survivors of severe disease, more than 700,000 children a year in Africa survive severe malaria with a brain injury, The commonest sequelae are epilepsy, which of course we don't know about when we discharge them, that comes later. They have motor and sensory deficits with neurodevelopmental delays, cognitive impairments, and behavioral disorders. Now, the optimist view of this would be, well, the good news is we have protective interventions that can prevent this disease, bed nets, intermittent treatment, intermittent spraying. There's lots of these out there. So there are good preventions. We also have better treatment. So in the old days when I started doing this work, you had quinine, you had 5 days of IV quinine. Quinine is horrible, awful drug to take. Now we have artemisinins. I can clear your parasite in 6 to 12 hours. That's great news. We have vaccination programs that are providing some protection, not awesome, but some protection against severe disease, and eradication efforts, maybe. That's the optimist perspective. Well, let me show you. I pulled the numbers from this slide 11 years ago. Note that the numbers are up. The numbers are not down, despite the optimist perspective. The numbers are up. We're now looking at 282 versus 214 million cases, 610,000 deaths, not 438,000. We're moving in the wrong direction. And what is the reality? And I'm going to spend a little time on each of these. Eradication efforts have failed. They have failed. They will continue to fail in really highly populated regions. Sadly, our public investments in preventive efforts were on the decline even before USAID closed, and that is not going to help. Climate change is playing a role. I will spend a significant time talking about how existing guidelines are outdated, terribly outdated, particularly with regard to what we know about neurologic disorders. And part of this is the reality that people with neurologic disorders, including epilepsy and developmental disabilities, are marginalized at all levels. What about eradication? If you're in public health or parasitology, you know that there was a big push for eradication for many years. The mathematicians told us from the beginning that if you had a high density population with a large proportion of people that had asymptomatic parasitemia, you were never going to eradicate. We ignored the numbers, they were right, and we have not eradicated very many places. And certainly most of the regions where I work, it's just not possible. Now you might say, well, you could eradicate if you could do mass treatment. Well, guess what? Our antiparasitics are suffering from drug resistance everywhere. They don't work in parts of Southeast Asia already, and that is only getting worse. We've had genetic shifts in the parasite that have made our rapid diagnostic tests useless in some areas. So that is not helping with eradication or care. And as I mentioned before, political will is waning. The issue with preventive efforts is they do work, but when political will wanes and resources aren't available, they end up being taken up by wealthier communities or politically well-established communities that can leverage public support for these. So what you end up with is, even within the same country, marginalized populations, the ethnicity that is least powerful and least popular with the party in power, all of those end up continuing to have exposure. And then, of course, chaos and conflict will amplify all of these. And if you look at rates of internally displaced people and wars, those are not waning either. What about climate change? So climate change is doing a funny thing. It's moving malaria out of some regions, but into others. Out of some regions is great, but when malaria moves into a new area, you have a change in that everybody is susceptible. If you go to a malaria endemic region, an adult gets malaria, it's like a bad flu, they do fine. They might do fine even without treatment. When you move malaria into a place where it hasn't existed before, the entire population is susceptible. So your population of who's at risk changes hugely. The care providers there don't know how to take care of the disease. It's not one that's always been there. Mobilizing the resources to suddenly provide care is really difficult. And you also have this strange problem that the resources, when we look at like malaria research centers, they're in places like Kalifi and Blantyre, and these are big infrastructure, big labs, lots of trained personnel. Those are not easily relocated to areas that suddenly have the disease. So our best malaria research centers are sitting in places that don't have much malaria anymore. But if you go to rural Congo, I can tell you where 16% of the global burden of malaria sits. There's plenty, there just aren't very many researchers or care. What about malaria care guidelines? So important to recognize that in malaria endemic regions, most of the care is not directed by physicians. And this is bad news, but it's also good news because, as you all are probably aware, physicians aren't great at following guidelines. Kind of have to beat them into it. A clinical officer and a nurse they live by their living is following guidelines. So guidelines are great in a lot of LMIC areas because if you give them the resources, they'll follow the guidelines. But also resource allocation is dependent upon the guideline. The government is only going to buy what's in that guideline. If care is not in that guideline, it is not, nobody's going to be trained to provide it. The resource is not going to be there. So I think in these environments, guidelines are much more important than you might imagine when you're in a Western setting where physicians kind of have their own way of doing things. This just is congruent and complementary to what Dr. Diaz showed, which is that we just don't have a lot of neurologic expertise in these areas, sort of next to none. And so you don't have local experts advising on care. The guideline from WHO is the local guideline. So it's very different than maybe in our own US system. So I'm going to drill down into what that looks like. And I'm going to do it just think like a neurologist and think about the guidelines. These are WHO guidelines I'm showing you. What do we know about cerebral malaria? We know that seizures and status epilepticus are ubiquitous. We know that 20% of the kids in coma that come in that had never had a clinical seizure are in subclinical status if you put an EEG on their head. We know this. We know they come late. What's the guideline? Airway protection and benzos. That's the guideline, 2024 guideline. No mention of second AEDs, even though you need them. A mention of paraldehyde. Maybe it's available in Latin America, no longer available in Africa. So not a great guideline. And we know that because of distance, we have delays in care. When you've been seizing for 2 hours straight, benzos aren't going to work, right? Benzos are not effective after seizures have been established for sort of more than an hour. Phenobarbital isn't mentioned, but it is the most common anti-seizure medication that can be given in an emergency in these settings. WHO efforts to improve drug regulatory capacity made phenobarb a scheduled drug, so now it's less available than ever. And ventilatory support isn't really available, and when you combine phenobarb and benzos, we know from clinical trials you increase mortality. So we don't have lots of good seizure options. There is data initially from my group and other groups have done it that show levetiracetam, even enterol-levetiracetam, can be therapeutic quickly within 45 minutes, that it's as effective as phenobarb, but safer, that it's cost effective, and it's not mentioned in the malaria guidelines. In fact, the only levetiracetam that's part of the essential medicines list is for oral chronic use in epilepsy. It's not mentioned for acute care at all. So there's a big gap between what we know, what is available, and what's in the guidelines. What else? Let's think about fever management. In malaria research studies, we know that a higher maximum fever during the acute malaria infection is a key predictor of neurologic injury and sequelae. For those of you who are clinicians, we know in the neuro world in general, if you have a brain injury, if you've just had a stroke, TBI, meningitis, anything, and you're allowed to have a fever in that period, that peri-injury period, your injury goes up. You have greater deficits. ICU protocols and MICUs, cardiac ICUs, neuro ICUs, PICUs throughout high-income countries recognize this. We do not let our brain-injured patients be febrile. Keep that in mind. And we know that the population of people with cerebral malaria are young. They're in that febrile seizure susceptibility. So just fevers alone could be part of the trigger for their seizures. What is the guideline? The WHO guideline is a standard dose of acetaminophen or Tylenol, a standard dose, not even a loading dose, and only if they have a fever above 101.3, which in all the epidemiologic studies is associated with a neurologic injury. There's no recommendation on the frequency with which fevers should be assessed. And many routine care settings will only be checking vitals on kids a couple times a day. We also know from several studies in several countries that acetaminophen alone doesn't actually lower malarial fevers. No single antipyretic does. So any single agent isn't likely to. And that if you wait until they hit 101.3, they've probably blasted past 102 because they come in with no fever and then they spike a very high fever. We've shown that in our observational studies. Work has shown that scheduled treatment, meaning they have malaria, we're going to treat them whether they have it or not, every 6 hours with oral standard dose ibuprofen, with acetaminophen that starts with a loading dose, reduces fever by all measures. These are cheap drugs. These are available. These are already on local regulatory approval throughout malaria endemic regions. And decrease seizure severity during the acute event. No recognition in the WHO guidelines of this reality. And so what do we know about the guidelines for follow-up care after severe malaria? Study after study after study, 5 countries, all the same. A third of severe malaria survivors from pediatric cerebral malaria sustain a brain injury, and if you follow them, you will see it. Sometimes you see it at discharge, they're hemiparetic. Sometimes you see it 9 months later when they have their epilepsy. But if you follow them for at least 3 years, a third of them have sustained a brain injury. They get epilepsy, developmental delays, language problems, cognitive problems, behavioral disorders, the full gamut. And for all of these things, epilepsy is a great example. Early intervention matters, right? You can get people on treatment before they have their first burn. You have developmental interventions that are locally effective in terms of helping mainstream patients. Early interventions matter. So what does our guideline say? There is no mention in the WHO guideline about following these kids up, about screening them in the future. There's nothing, even though we know as we send them out the door that a third of them sustained a brain injury, and it's only going to be recognized if the parents realize there's a problem and bring them back in. Really inadequate. Why this paradox? Why this bizarre disconnect between the guideline and what we know as neurologists and neuroscientists? Well, one potential explanation that's probably somewhat true is that the people in the trenches don't know a lot of neurology, and you don't recognize what you don't see. So the lack of local expertise is real, and that's from the nurse and clinical officer all the way up to a general physician who may well have been educated in a health sector that had no neurologist when they went through their training. This depicts that reality, and this is a little bit dated, but the white regions of the map are where they couldn't even find anybody who knew enough about neurology to tell them there were no neurologists. The purple in Zambia was me and 15 million people. Things are much better there now. So there are no local expertise. So could that explain it? But remember what I said, the guidelines aren't coming locally, they're coming from WHO. This is a WHO org chart. I don't need you to read any of this. Aren't you happy? But just to get a sense of this WHO org chart, where does neurology fall on this WHO org chart? Okay, there it is. Let's drill down into that. Now where does it fall? Right there. You'll notice it's the mental health and substance abuse section. That's where neurology falls. We have no real representation at WHO. The neurologist has always been second in command to the psychiatrist there, and neurology just gets no traction. And we could talk about the eye gap if you want, but neurology gets no traction. And this is the entity that's developing the guidelines. There's never been a neurologist on the malaria, the guideline committee for malaria care. There's never been a neurologist on that either. So with malaria, we see, and many neurologic disorders and LMICs, we sort of see inequities within inequities, that it impacts the poorest countries. Within the poor countries, it impacts the poorest communities. In the marginalized populations, they're more affected. and the disabilities that result sort of worsen the SES of that community. So care improvements in public health in these settings often neglect the most marginalized population, and the people with the least resources are more exposed to risks of malaria and have the poorer outcomes. It's kind of Russian doll effect, right? The paradox continues. If you look, for example, the World Bank, and I'm saying this because it isn't unique to malaria, the World Bank long ago declared epilepsy among the most top 5 cost-effective things to treat in an LMIC. Top 5. So why is there still an 80% treatment gap in most parts of LMICs and most of Africa, greater than 80% treatment gap? And even where treatment is available, I can tell you, we stock out of anti-seizure medicines long before the antihypertensives disappear. They are the first to go and the last to be ordered. And this has real meaning. So, for example, we did a study in which we had people with epilepsy, age, community, and gender matched to people in the same clinic with some non-stigmatized disorder. And we found lots of SES differences, including the fact that people with epilepsy were much less likely to have access to pumped water and much less likely to have access to a stove. Well, guess what the top 2 causes of death in an adult with epilepsy is? Burns and drowning. So it's a very wicked cycle, right? But just a very wicked negative feedback loop. And this is what we call my stigma stairs, which is just sort of how this stigmatized illness can kind of lead to a decline in SES and survival itself. But some of the key things to note is one of the problems is the conditions to treat this stigmatized disorder are less resourced, both in terms of medications and healthcare training across the board. So people might get treatment for other conditions, but their Parkinson's disease doesn't get addressed. Or people can diagnose it, but Sentimet didn't make it to the area, et cetera. So the macro level inequities are worsening the micro level inequities across the board. So in summary, neurologic disorders in Africa both result from poverty and cause poverty. Very vicious cycle. And this is universal. We've been talking about it all morning in the US, right? This is a universal phenomenon. But I think there is a unique problem in LMICs because neurologic care, the inequities in neurologic care are disproportionate to other things. Disproportionate to the care that's available for TB, to the care that's available for other things. And I think that there's some explanation. Part of this is limited local expertise. But I think we have to acknowledge that outdated organizational structures and guidelines play a big role in this, as does stigma and the burden of stigma in populations that have less health education and less education in general. And so what I believe, and I think there's plenty of data to support it, is the neurology as a discipline is marginalized globally, and this has consequences. Part of it is evident in the power structures. You saw where neurology, how high it falls up on the WHO list. We have a problem of therapeutic nihilism. Everybody in this room, who most of you are younger than me, the decade of the brain happened, and we have great therapies for so many neurologic conditions. But much of the LMIC world has not experienced that advance. And so we have generations of physicians and policymakers that kind of think neurology is the diagnostic wonder for which you can do nothing, and they just don't want to go there. They don't want to be dealing with a disease they can't afford to treat. Totally not true, but we haven't done a good job of educating them. There's an issue with power structures and good old boy systems and a resistance to change that we see everywhere, but it's very hardwired in this particular environment. And then, much as I would like to cheerlead for the global burden of disease, the ugly little secret about the global burden of disease is it drags everything back to the root cause, which is great from a public health perspective. But if you think about that, if you have epilepsy from malaria, they're going to give that burden to malaria. They're not going to give that. That's fine, except the malaria doc isn't taking care of that epilepsy patient. The neurologist is. And so the root cause analysis from a public health perspective is fine, but the numbers don't reflect who the care providers are of the end condition. And so policymakers are looking at GBD, and they're actually discounting a lot of neurologic burden as falling into other buckets. even though it's still quite high. And so, and they don't this is not truth in advertising. GBD data does not tell you how they've categorized things up front. We lose a lot of neurologic burden, kind of leaks out. And so policymakers are not adequately informed. So how can we reduce these? And I just, partnership and capacity building for local expertise is critical. We have a wonderful postgraduate neurology training in Zambia that is just transforming the care in the country. I can't say enough about it. We need, when we have new experts, you know, one of the things I'm learning is that we really have to continue to support them. We bring young neurologists from their fellowship back to Zambia. And if we don't watch ourselves, they suddenly are running a hospital or a health system, and they really need support. You can't imagine finishing your own clinical fellowship and the burden that's there and the lack of support. So we not only need to build them up, but we need to be there for them after we build them up. We have to invest in research and capacity building to develop evidence to inform policymakers and guidelines. Stigma reduction activities and research are critical. And then I think we need to advocate globally for neurology as a discipline. We don't necessarily do that well. If you're in the global neurology field, you really have to be willing to accept and seek leadership roles. You have to mentor broadly. And importantly, and I hope to be doing this soon, cede our leadership, our power, and our resources to our local partners as soon as they're capable of taking that on. It's really easy to kind of dig in your heels and stay forever. And that's fine to stay, but let other people be the leaders. I think that's very important. And I'd be happy to take any questions.
Thank you for that excellent talk. Even though my area is not malaria, and I assume most people in the room are not experts in that, I certainly can see relevancy across many conditions as well as many geographic areas. So any questions from the audience or online? Yes, can you turn on the microphone?
Yes, thank you very much for fascinating but somewhat pessimistic talk. Really and truly, I mean that. And it was a brilliant presentation. And I'm just wondering, WHO has a very long way to go, and it really leaves you feeling pretty flat that nothing's been done. It's clearly something that needs to be changed. So as a legitimate question, I would ask you, have you ever thought of yourself with your extensive, vast expertise, thought of inserting yourself along with like-minded global neurologists, maybe working within the American Academy of Neurology or the World Federation of Neurology, and just make it a major goal to make a change here instead of, it's really a very pessimistic feeling because clearly so much needs to be done and you know what to do. How about yourself? I mean, thank you.
So I mentioned the IGAP, which the World Health Assembly signed on to, a certain number of countries signed on to neurology care. I actually think our best hope is in that generation of neurologists who are coming up in these LMICs. And I think I'm already seeing them change. That's where the change is going to come from. It's going to come from within. It's not going to be, you know, some high income entity or country writing in to save. I think our best hope is training a generation of excellent neurologists and neuroscientists who then they're going to bring the change from the grassroots up. And I'm seeing that beautifully in Zambia. And I know that there are lots of efforts to do this elsewhere. So it's kind of a different model, but I think that, and in that regard, I'm very optimistic, very optimistic.
Yes, go ahead.
Great talk and great work as always. I've been thinking a lot about how to translate my own work to the US or more on what kind of impact global health and neurology can have on the US. And I think like malaria, for example, which has very little impact on the US. I'm just wondering how you are trying to kind of translate your work between that.
For better or for worse, malaria is the best human model of epileptogenesis you can imagine. It's very predictable. it develops quite rapidly. Within 9 months, within 2 years, we're seeing 10, 15%. So it's a great model for studying epileptogenesis. And that, of course, is, from an epilepsy research perspective, is the holy grail, because most epilepsy research is talking about epilepsy as an end disease as opposed to what we could be doing acutely. And there have been many studies that have tried to do it, but TBI is too heterogeneous. There's just stroke is too heterogeneous. So I think, honestly, if some of our modest neuroprotective interventions work in cerebral malaria, it may inform using those same simple, neuroinflammatory preventative agents in other conditions. And they're also very safe. So I do think it has relevance to human health everywhere, because there's epilepsy. If you get cortex, you got epilepsy around.
So I just kind of wanted to make a comment about that as well. So I mentioned to Dr. Birbeck earlier that it was 2008 that she did a grand round at Hopkins when I was a resident. And I really got interested in global health and neurology from that. And I thought I was going to do neuroimmunology. And then I went to Senegal, and there was so much stroke in Senegal. And it really was, even though I was working in Baltimore, it was the best demonstration of what disparities and inequities look like, and also understanding the mechanisms of disparities and inequities. So I think there's so much that it's amplified greatly, but there's so much that we can learn about the underlying mechanisms for diseases here, working communities here. So a lot of the same things and approaches can be actually applied to disparities in the US.
Amen.
Yes, please.
Hello, great talk. So I come from Ghana, and malaria is endemic in Ghana. And we are beginning to see a very interesting trend in Ghana. Even though malaria is endemic, as the socio-economic gap widens, there are certain communities that are becoming a little removed from this endemic area. And anytime there's like a malaria surge, this population tend to have now like severe malaria. So even in endemic communities without like proper eradication, we are seeing like a repeated vicious cycle. I worked in Zambia for a month, but I'm just curious what like the experience is in Zambia, whether you're also seeing like a similar trend, that there are certain communities, even locally in those endemic regions, that are also getting like severe malaria, where historically they were protected from severe malaria.
So yeah, this is a good question. So what we do see, we've had malaria totally disappear almost from some of the southern province as climate change has really dried that region out. And what's phenomenal is we used to have a lot of malaria in Lusaka. When you saw severe disease in Lusaka, it was an under 5 child. Now on both the adult and the ped side, we see it. And I can tell you, it's like clockwork, 2 to 3 weeks after holidays, when everybody from the city goes and visits Granny in the bush, and they get their exposure, but they've grown up and lived in a non-endemic region. And so we see it in older teens and young adults. So we're seeing it more as a result of people going back to where their family came from, where there's still lots of malaria. And the real danger, if they go to like a private clinic with especially like expat physicians, nobody thinks of malaria. Well, they're from Lusaka. And if they don't get a travel history, we're seeing people who've died because of that. So we see it when people are going back and forth between more traditional places their families came from, which are often, a 3 or 4 hour drive from Lusaka. You don't have to go that far. So, yeah.
So Gretchen, fantastic talk, no surprise. But the question I have for you in terms of solutions is, this is part of what SEQUINS was formulated for, to be small, but to help drive the conversation forward. So we are a member of the World Health Organization Civil Society Commission. We're a member of the International Science Council. And to your point, it would be wonderful to build it from the ground up, but that might take some time. So can SEQUINS partner with WHO Civil Society, with the African Academy of Neurology, convene experts such as yourself and others in the room or online to try and put together some guideline to set the ball rolling, kind of dragging people along, so to speak. Moving, Dr. Nichols is leading our first guideline in another realm, but just wondering how SEQUINS could potentially, again, just drive things forward before we start to have this critical mass of Africans doing it.
That's a really interesting question. I mean, I think that there are efforts, WFN has things ongoing, et cetera. I think the framing sometimes doesn't acknowledge that the inequities in the discipline itself is part of the driving. And I think that that piece of it hasn't been brought to the table. Everybody's thinking about the global economic differences between the North and the South. And what I'm saying is, like, we're talking about disciplinary differences. And I think if there's a way of highlighting that and getting that framing into the minds of policymakers and leaders, it might make a difference, because it is a different way of looking at it that is getting away from the just have and have nots on an economic basis, but just recognizing the marginalization of an entire discipline and the people associated with those conditions.
Great, thank you. Rael, is there anyone online? Any questions? Okay, great. Thank you all for the wonderful conversation, and also thank you, Dr. Birbeck.